A typical endocrine system maintains a precise baseline rhythm. In a small subset of the population, this cyclical architecture collapses, resulting in a systemic disruption that repeats with every cycle. This data indicates that 3 to 8% of the menstruating population experiences this distinct pathology. Clinicians frequently misidentify this specific group as having standard premenstrual syndrome, overlooking the severity of the underlying condition. The clinical term for this specific neuroendocrine disorder is Premenstrual Dysphoric Disorder, or PMDD. The DSM-5 provides a formal psychiatric classification for PMDD, establishing it as a condition that requires a rigorous medical evaluation. Confirming a diagnosis requires navigating a series of rigid symptom logic gates and specific temporal constraints. To understand the disorder, we must deconstruct these diagnostic criteria and examine the evidence-based treatments that address them. Precise categorization is a clinical necessity. Applying steady-state treatments to a cyclical condition often fails to address the unique timing of the symptoms. The first logic gate in the DSM-5 framework is a strict quantitative threshold. This flowchart illustrates the requirement. A patient must present with at least 5 distinct symptoms across 2 distinct categories. Category A consists of core affective markers, marked mood swings, significant irritability or anger, feelings of hopelessness, and intense anxiety. A valid diagnosis requires at least 1 symptom from this core affective list. Without this marker, the criteria are not met. Category B tracks secondary somatic and cognitive symptoms, such as concentration difficulties, lethargy, significant changes in appetite or sleep, and a subjective sense of being overwhelmed. When the sum of symptoms across both categories reaches 5, the patient has cleared the first diagnostic requirement. This requirement ensures that a PMDD diagnosis is based on a multisystemic cluster of markers, rather than the severity of a single symptom. Symptom counts alone are insufficient for a clinical diagnosis. They must also align with a highly specific chronological pattern. We map the severity of these symptoms against a continuous 28-day timeline. All 5 symptoms must emerge exclusively during the final week before menses, known as the luteal phase. These markers must then begin to improve within a few days of the onset of menses. Finally, the symptoms must clear entirely during the week following menses, showing a return to the patient's baseline state. This specific on and off pattern distinguishes PMDD from steady-state conditions like major depressive disorder, where symptoms persist throughout the entire cycle. To prevent misdiagnosis based on recall bias, the DSM-5 requires perspective tracking. A clinician must document this specific timing across 2 consecutive cycles before a diagnosis is confirmed. The menstrual timeline functions as the primary diagnostic instrument, as PMDD is defined by these rigid chronological boundaries. Once the symptoms and timing are established, we must examine the real-world consequences of the disorder. The diagnostic criteria require evidence of meaningful impact on the patient's daily life. Evaluation focuses on 3 specific spheres: occupational, academic, and interpersonal functioning. The patient must show documented impairment in at least one of these domains, specifically during the luteal phase. When this functional disruption is confirmed, the criteria for a clinical PMDD diagnosis are complete. Confirming the temporal architecture of PMDD allows for the application of highly specialized treatment protocols. PMDD-focused cognitive behavioral therapy serves as a continuous intervention spanning the whole month to build long-term psychological coping strategies. Pharmacological treatment specifically targets the underlying neuroendocrine shifts. SSRIs are an evidence-based option, but their application in PMDD is unique. Clinicians can prescribe SSRIs exclusively during the luteal phase, intercepting the symptom spike without requiring the patient to take medication every day of the month. Another pathway involves suppressing the hormonal fluctuations that trigger the cycle. Combined hormonal contraceptives containing drospirenone are used to stabilize the endocrine axis, effectively preventing the luteal phase symptoms from developing. Because PMDD involves both psychological and endocrine elements, successful management requires coordinated care between therapists, psychiatrists, and OB/GYNs. Utilizing the rigid DSM-5 criteria provides a standardized, evidence-based path forward, replacing clinical guesswork